You're live. All right, so this is Senate Health and Welfare. We're back on April 1st, and we're picking up some testimony on H611, which is the bill relating to miscellaneous provisions affecting Department of Vermont Health access. And Tess Bettler is here from Compass Pathways. And Tess, why don't you introduce yourself for the record and let us know what Compass Pathways is, and then your interest in the bill.
Absolutely. Again, thank you so much for your time. My name is Tess Bettler. I'm the Associate Director of Government Affairs for Compass Pathways, and Compass Pathways is a biotechnology company investigating synthesized psilocybin for treatment-resistant depression and post-traumatic stress disorder. And I'm happy to continue with my testimony.
Please go ahead. Thank you.
Excellent. Good morning, Madam Chair and members of the committee. My name is Tess Bettler, and I am the Associate Director of Government Affairs at Compass Pathways. Thank you for the opportunity to testify once again to our amendment request. We respectfully ask the committee to include language in H611, the Miscellaneous Department of Vermont Health Access Bill, which will automatically align Vermont law with federal scheduling decisions, allowing FDA-approved psilocybin therapies to be prescribed and administered in a medical setting in Vermont without delay once approved and rescheduled. Vermont is facing a significant and ongoing mental health crisis with treatment-resistant depression and post-traumatic stress disorder continuing to impact thousands of residents who do not respond to existing treatments. As outlined in prior testimony, investigational COMP360 psilocybin treatment has shown promising clinical results and has received FDA breakthrough therapy designation. If approved, it would represent a fundamentally new treatment option for patients with few alternatives. However, without proactive state action, Vermonters could face unnecessary delays in accessing this care. Because psilocybin is currently a Schedule I substance, state statute must be updated following federal approval and DEA rescheduling before it can be prescribed. Vermont has taken this step before with cannabidiol, ensuring timely access to new therapies. Including the proposed language now in H611 ensures the state is prepared. It creates a clear, regulated pathway for prescribing, dispensing, and administering this treatment under medical supervision while maintaining appropriate safeguards. Most importantly, it prevents avoidable gaps between federal approval and patient access. We urge the committee to act now to ensure that, if approved, this innovative treatment is available to Vermonters as quickly and safely as possible. Thank you for the opportunity to testify and your consideration to our request.
Thank you. Questions? Okay.
Senator, comment?
Yeah.
Just a comment really is that I'm obviously very much in favor of this. I have been trying to work toward the therapeutic use of psilocybin for a while now, just given our mental health challenges, and it's being more and more trials are being done on how effective it is for PTSD and treatment-resistant depression. So I'm hoping that we can
We'll look at it in as we go through the markup of the bill. So just remember the comments that were made here, and we'll see where it fits. That's the problem. What's the problem we're trying to solve? Why? So Tess, can you tell us what problem it is we're trying to solve with your recommendation?
Absolutely. Yes. The problem underlying all of this is the scheduling of psilocybin. So federally and in Vermont, psilocybin is currently illegal. At the federal level, it is Schedule I. If this treatment was to be FDA approved, it would move at the DEA level from Schedule I to a lower schedule, essentially making it legal within the United States. However, in Vermont, an additional state action needs to be taken in order to make psilocybin or an FDA-approved psilocybin product legal, which is what this bill would solve for. We cannot ship and prescribers cannot prescribe within a state unless and until the scheduling is taken care of. I hope that answers the question.
Does the scheduling?
federal government.
No, at the state level. I'm trying to figure out, do we need to take action now because we have to come back next year and approve it? Or is it just a state agency that's here and active?
Yeah,
we're not in session.
Right. I believe that the legislature needs to take action on this, and then the department also needs to do some rulemaking. But ultimately something needs to change in statute before this can be administered to the public, to patients.
Okay. So we'll have a discussion about that.
Yeah, I'd like to hear.
Right, and we'll hear testimony. Obviously the department and others will have to testify on that. Okay, thank you. Any other questions for Tess? All right, terrific. So we'll move on to Laura Byrne. Also up here on our screen, welcome.
Thank you. Good morning. My name is Laura Byrne, and I'm the Executive Director of the HIV/HC Resource Center, and I'm here to testify on behalf of the 3 AIDS service organizations. That includes us, Vermont Cares, and AIDS Project of Southern Vermont. And we're back to ask that you include our proposed amendment related to PrEP, pre-exposure prophylaxis for HIV, and PEP, post-exposure prophylaxis, in H611. Since I previously testified before your committee on this issue, I'll just briefly reiterate our support for the amendment, which has been submitted for your consideration. PrEP remains significantly underutilized in Vermont, despite the fact that it meaningfully reduces the risk of HIV infection associated with sex and injection drug use. PEP can prevent an HIV infection if it's used within 72 hours of exposure. Access to these medications is a proven health public strategy that also produces significant cost savings. Preventing a single HIV infection can save a healthcare system approximately $554,000 in lifetime medical costs. Given the ongoing instability at the federal level, Vermont must establish its own legislative authority to ensure that access to PrEP and PEP is broad, reliable, and free of unnecessary barriers. Barriers such as cost sharing, prior authorization, and limited prescribing continue to delay or prevent care for people at risk of HIV. I'd also like to mention that we support allowing pharmacists to prescribe and administer PrEP and PEP, as many states already do. This will increase access, particularly in rural and underserved communities where timely care can be difficult to obtain. Thank you for your time and for your consideration.
Okay, so this, there's obviously an expense to adding this in. With the culture covered, out of pocket being covered as it's drafted.
We just feel that it's very important to get the legislative language in right now in case the federal guidelines change.
Okay. Federal government is just not predictable. That's what we're hearing.
Is it covered under federal guidelines now?
Ask her that question.
Is it covered now? Or would this be a new expense to the
It
state?
is currently covered.
By Medicare, Medicaid?
Medicare, both, I think.
Oh,
We're concerned that the guidelines might change.
and so your concern is the guidelines might change, so let's put it into coverage right now for our Medicaid program.
That's what we'd like to do. And we'd also like to expand prescribers and allow pharmacists to prescribe, which would increase access.
Okay. All right, good. We'll get further testimony on this. This is not something that happens overnight, but thank you for the proposal. And
Thank
similarly,
you.
same thing with psilocybin. We're gonna have to, look at both of those together. And then look at the number of folks who would be subject to this and then what the coverage costs would be. All of that information we're gonna have to. Okay, thank you very much.
Thank you.
All right. So now we have the Director of Public Policy at Bi-State Primary Care. Mary Kate Molman. Madam Chair. Welcome. We haven't seen you recently.
I haven't been at this table, so let's see, share.
So it wasn't that long. It was last week.
I know. It was just yesterday. So it's
Right. All right, thank you, Madam Chair, members of the committee. My name is Mary Kate Molden. I am Director of Vermont Public Policy with Bi-State Primary Care Association. Just as a reminder, we support our Vermont's federally qualified health centers. We also support Vermont's free referral clinics and Planned Parenthood. So we are here to propose an amendment to H611, specifically Section 2. This is the section of the bill that currently has an amendment on or repeals a section of Act 55, which this body passed last session, which provided protections for the 340B program for covered entities participating in the 340B program. I will say on the onset, like that repeals the rebate program. We don't love it, but given everything that's happening at the federal level, we're not going to oppose that repeal. However, we would like to add an amendment to Act 55, which closes a loophole we think is important for our members. So just briefly, on a 340B program, I know Jen often comes in and walks everyone through high level. For manufacturers to participate in the Medicare and Medicaid programs, they must also participate in the 340B program, which means they must offer reduced or prescriptions, drugs to covered entities, which are federally qualified health centers, the Ryan White clinics, certain hospitals, other safety net providers, offer those drugs at a reduced price. So those entities buy those drugs at a reduced price, and when they prescribe them out, they then get reimbursed at the full rate. And so that savings they have by not spending the full amount when they purchase the drug is then used to support care in other ways. So that's the high level. If you want to dig in a little deeper, we've got this nice kind of flow diagram, which walks you through how the savings works and how the different parts of the system. I don't want to get too deep unless the chair would like me to. But essentially, federally qualified health centers are required by federal statute to use these savings to benefit patient care. We use these to reduce the cost of prescriptions for those who qualify for financial aid. We increase access to oral health care. This can go to free care for people who are uninsured, or even Medicare individuals, because dental is not covered under Medicare. So if they can't afford it, then they can get some support through our federally qualified health center dental services. To go to expanding mental health care, substance use disorder treatments, nutritional security, transportation, translation, and the other host of services that patients at federally qualified health centers get access to. So Act 55, what did it solve? It really helped protect covered entities participating in the 340B program. And specifically, it protected their ability to contract with community pharmacies to continue to be part of the 340B program. And it also prohibited manufacturers from requiring burdensome reporting obligations at contract pharmacies. It also, one of the criticisms of this program has been the lack of transparency. So Act 55 addressed that by requiring hospitals to submit significant reporting for how the money they receive through the program and how they spend it. Again, the FQHCs were left out of that because we are required by law to use for patient care. What the loophole that we have since identified, and we did not include it last time because manufacturers at the time were explicitly excluding in-house pharmacies from reporting. We are now seeing manufacturers requiring in-house pharmacies as well as contract pharmacies to go through all of this onerous reporting requirements. In Vermont, the contract pharmacies are now explicitly prohibited from, or the contract pharmacies are exempted from this reporting, but our in-house is not, and we're starting to see that to be a problem. So
Can you tell us, give us an example of a contract pharmacy?
it could be, I'm trying to think specifically, it could be like Walgreens,
Yeah, like a CVS,
CVS,
some of the bigger.
yeah,
That are all like PBMs.
PBMs are also prohibited. We did pass a law that prohibited PBMs from pickpocketing this program as well. So how are we asking to close the loophole? Five little words. That's all we're asking. Taking this section B in Act 55, adding after contract pharmacy or a 340B covered entity. That would include our in-house pharmacies and close the loophole. So, questions?
Who's against this?
I imagine
I'm sorry.
manufacturers.
That was a rhetorical.
Wow, okay. It's great. I don't have.
Questions? Okay, so it simply closes the loophole and just everyone's covered the same.
Yep.
In terms of
Yep.
reporting.
Yep.
Helps that problem. And yeah, well, go ahead.
So, I'm trying to get this right. So the manufacturer's getting less money. Who's getting the less money? You had a kind of a chart there. that
Yeah,
was trying to follow.
the manufacturers by
They're taking in less money
through this, yeah.
through this program, 340B.
Yeah.
Yeah.
So I'm only guessing, but I'm guessing the manufacturer's gonna get that money back. And
I mean-
what they're going to do is increase pricing perhaps somewhere else.
So maybe go back to the program was established to ensure that low-cost drugs are available at the patient level. And it's done through various pharmacies that qualify. So maybe you could begin with that, because I think that helps. It keeps the pharmaceutical manufacturers from setting a price that is not in any way regulated. We don't.
Yeah, so this is a very complicated
I shouldn't have asked. the question.
program. No, it's a good question.
question.
And I want to reiterate, this is, if you were to start from the beginning, this is not how anyone would want to fund our healthcare system.
No.
Oh,
Yeah.
But it is what we have, and it has been critical to keeping the doors open for our safety net providers. This is, if this money were to go away, we'd see fairly qualified health centers closing in Vermont. So that to get to your question, it's a little more complicated than that. So the federal government requires manufacturers, if they are going to participate in the Medicaid and Medicare programs, which is a pretty substantial book of business.
Yeah.
They then have to offer these reduced prices to these safety net providers.
Okay.
And the idea here is that this becomes then a source of funding that our safety net providers can use to support patient care, and let the federal dollars that they receive in other avenues also stretch a little farther to support patient care. So it's, if you read the federal statute, says, I'm not sure I'm gonna get the quote exactly right, but it is to stretch scarce federal dollars further.
I guess my only point is, okay, so they're not, they're protecting through Medicaid, Medicare, federal government, all that stuff, but the commercial side of things is probably going to pay all of it.
I can't speak
so
to
we
that.
have,
And there's also, like, if they increase the rates, if manufacturers increase the rates, then by a certain amount, then the savings become exponentially bigger
For
for.
you, for the
Yes.
340Bs.
So if you see manufacturers losing a lot of money, it's because they're increasing the money, the price faster. And I don't want to get too deep,
Okay.
and if we
here's
need
what we're
to
going to do.
get some experts.
When Jen comes in.
Yeah.
We'll go through 340B so that so that you understand, Senator, a little bit better,
Okay,
that we have been through this in here as recently as last year at this time and before, so
I just see a question on the floor coming up on that.
yeah, we'll be good. So the issue isn't so much who's losing money as how can we protect the folks who are within our safety net.
Yeah.
And so, yes, so there are savings in at the 340B.
Yeah.
So what happens is the drug is sold at a lower price
Yeah.
here. And then the pharmacy within the 340B organization can sell it slightly higher. And then the difference between that is money that is profit.
Yep.
And that profit is taken and invested in patient services.
Yep.
So it lowers the cost overall for two things. The drug itself and the services.
Yep.
And there's always been this big tension about, well, we're taking money from the manufacturers, or how can we guarantee that this little bit of this extra income is going for patients? And we debated that and we did that. We've been through that. So this question is about who should be reporting about that lower drug cost that they're getting. And so the larger organizations like Walgreens or CVS or others are getting this benefit and this, but they're not reporting back. So we're just trying to understand what's happening between here and here with those few organizations. That's where we are.
Okay,
You've lost me. Okay,
I
well,
caught you.
yeah, so
I thought 340B went to hospitals, not to Walmart.
Yeah.
And that hospitals, this was the drugs that when they charge me an outrageous
Right.
price for an aspirin, they're paying a lot less for. They're supposed to put that profit differential
into the patient.
into patient service that HQHCs do dental, which is, or you want to see a court remoter, look for someone with no teeth. I mean,
So
dental service is very expensive and people don't get it.
So the question you're asking is what we'll
How
ask,
does Walmart get it?
so it didn't, we had, but so what we'll do, Senator, because this is the question of the day. What does or a 340B covered entity mean? Who's included in that?
Yeah.
That's why I asked that question. So Jen will come in and we'll grill her on that and we'll get the answer.
It's just how the money flows. And then you also said, oh, I forgot. I lost it. Okay.
Okay, we'll get it. We'll get it. It'll come back to you. Write it down.
Yeah.
And then we'll come back and look at the bill again and we'll look at the language. As it may or may not fit in the bill.
Yeah, and I will mention just the burden. We were talking about this yesterday with our members. The administrative burden is significant. We're talking about 1 to 2 FTEs needed to figure out all of the reporting around the 340 program.
Wow. Sounds really.
Never said
You're in the wrong speed. You want something there.
Yeah. It's like, can't make this up.
All right, well, thank you.
Well, no, thank you.
Yeah.
It's helpful. Now we know where we're headed and what your interests are. And we do want to fix any problems with prior legislation. So this is one of those.
Yeah.
I view it as a technical.
It truly is a technical
Understanding.
All right, thank you very much.
Thank you. So we have Logan Davidson online. Logan, thank you for being here. So
Thank you,
why
Chair, and
don't-
let me,
Yes, so Logan, why don't you introduce yourself for the record and then I think, do we have your testimony?
I have my screen shared with it and I can email it over as well after I
Terrific,
finish if that
that's
works.
good. If you can enlarge it just a tiny bit, we'll be able to read it better. while you're going through. A little more.
How's that? Is
that's-
that good?
Yeah, very good. Thank you.
Okay, perfect. And my name's Logan Davidson. I'm the Legislative Director of Veterans Exploring Treatment Solutions, which is a 501c3 nonprofit organization with a mission to end the disproportionate incidence of suicide among American veterans by underwriting treatment grants for Special Operations Forces veterans seeking psychedelic-assisted therapies for PTSD, traumatic brain injury, and other mental health conditions. And we are here to support the proposed amendment to 611 that would automatically align Vermont law with federal scheduling decisions, allowing FDA-approved psilocybin therapies to be prescribed and administered in a medical setting in Vermont without unnecessary delay. We thank you for the opportunity to speak today about the urgent need for new treatments for veterans struggling with post-traumatic stress, traumatic brain injury, and other service-connected conditions. Since 2019, VETS has provided financial and organizational support, including preparation and integration coaching, to over 1,000 veterans and veteran spouses through our Foundational Healing Grant program, enabling them to travel outside the United States and access life-changing psychedelic-assisted therapies. The fact that these veterans must leave the country to access potentially life-saving treatments underscores exactly why legislation like this amendment matters so deeply. The veteran mental health crisis has reached staggering proportions. Since 2001, over 125,000 veterans have died by suicide, and 29% of global war on terrorism veterans are known to suffer from PTSD. The disproportionate incidence of PTSD among veterans is a direct driver of the disproportionate incidence of suicide among them. We lose no less than 17, and by some estimates, as many as 44 US veterans to suicide every day, nearly double the rate of non-veteran Americans. This urgent crisis demands swift action to expand access to novel, effective treatments. Existing treatments for PTSD and treatment-resistant depression often fall short for many veterans. Conventional therapies provide limited relief and rarely address the root causes of these conditions. The only FDA-approved drugs for PTSD are selective serotonin reuptake inhibitors, SSRIs. And while they show an overall response rate of approximately 60%, only 20 to 30% of patients achieve complete remission. Far too many veterans continue to suffer without effective care. Fortunately, we are seeing significant progress in the field of psychedelic research. Psilocybin has received FDA breakthrough therapy designation with clinical data demonstrating promising results for patients with treatment-resistant depression and PTSD, conditions that disproportionately burden Vermont's veterans. These therapies offer a level of potential effectiveness that traditional treatments cannot match. But without proactive action by this committee, Vermonters could face avoidable delays in accessing this care once it receives federal approval. This amendment takes a responsible, evidence-based approach that Vermont has used before. The state has already enacted this kind of proactive scheduling framework for cannabidiol. This amendment applies the same sound, forward-looking logic to FDA-approved psilocybin therapy. It does not legalize or decriminalize psilocybin. It simply creates a clear, regulated pathway for prescribing, dispensing, and administering this treatment under medical supervision, ensuring that once federal authorities have determined a therapy is safe and effective, Vermont's laws will not stand between a patient and their doctor. Other states have already taken this step. Arizona, Colorado, and South Dakota have all enacted similar trigger legislation, and they did so with bipartisan support. It is important to recognize that this is not a red state or blue state issue. It is not a matter of Democrat or Republican, liberal or conservative. This is an American issue. Veterans from all walks of life have sacrificed for our country, and it is our responsibility to ensure they have access to the best possible care as expeditiously as we can provide it. Our government sent a generation to war, and now it is our duty to care for the invisible wounds they carry home. After 2 decades of sustained combat, our veterans deserve the best possible care. We urge this committee to include the amendment in H611 and position Vermont to provide timely access to therapies that can truly heal those wounds and save lives. Thank you for the opportunity to address the committee and for your leadership and commitment to our nation's heroes. VET stands ready to assist in any way possible to support the successful implementation of this initiative.
Thank you, Logan. Very helpful. Questions? Go ahead, Senator.
I didn't know what psilocybin was, so I just looked at it. It's a
Mushrooms.
yeah, I didn't know that.
I didn't either. Oh, we should have done that. Logan. You know, from,
No idea what it was.
oh golly, Ned. Okay, so no, Logan, from your perspective, can you share with the committee what your understanding of is what psilocybin is and what it does, what the active, how the active ingredient might, what you know about it?
Yes, yeah, absolutely. So psilocybin, is a naturally occurring compound found, colloquially known as magic mushrooms. What we're talking about here would be pharmaceutical psilocybin, which is a synthetic compound. And the way that it's delivered traditionally, so for example, veterans who we have sent internationally to countries where it's legal to access, the psilocybin is administered under medical supervision and with support from a licensed mental health care provider. And so what that usually entails is a treatment room, a little bit more comfortable than your traditional like doctor's office, right? Better lighting, more comfortable chairs, closer to a therapist setting than a physician setting. And then folks are able to take the medication. There's some time where you wait while it takes effect. Sometimes folks listen to a specially curated playlist. Sometimes folks just sit and kind of meditate or with their thoughts or have conversations with that licensed mental health care provider. And then different folks approach the treatment differently. Something we've actually found with a number of combat veterans is the PTSD does not originate in combat. It actually originates much earlier in life. And there may be a correlation between that early trauma and their decision to seek out a combat facing role, especially a special operations combat facing role. And folks are able to confront, and process whatever those traumatic experiences were with the support of that licensed mental health care provider. And what we found is it's the addition of this medicine that allows them to engage with those experiences, process that trauma, and find long-lasting healing. It also, in addition to the mental health side, there is a physical health component. Psilocybin is very positive on brain activity and can actually increase neuroplasticity, which allows the brain to learn. Again, as we get older, our neuroplasticity goes down, so it allows you to learn, and so you can relearn things. So if you fell into a fixed negative thought pattern about yourself, about your experiences, say a moral injury component, this allows you to re-engage and re-understand how those things happen and find long-lasting healing. And that's what's so important, is that it's not a medication that you take every single day. It's not a maintenance drug. It is a medication and a treatment that allows folks to reach remission on their post-traumatic stress disorder symptoms, for example, and then fully re-engage with their family, with their community, with their work. And that's what we're really looking for, is that kind of foundational healing. That's why we call it the Foundational Healing Grant Program, that resolves these issues at the source rather than just treating the symptom.
Thank you for that. That's helpful. What you've described is a very special therapeutic process for folks with TBI or PTSD. And
Absolutely.
Yeah. So, and this committee has heard testimony previously about the use of psilocybin. I know that California has quite a system for doing that and training for folks who work with people with this psychoactive drug. It's a good question. And so I know what they know. So Logan, thank you for that clarity. We will we'll consider your recommendation, and as well Tess. You've also, did you want to comment at all about this further?
I just wanted to make one final comment, just re-emphasizing that the language that we're asking for would ultimately just provide access to an FDA-approved treatment, right? Something that is approved at the federal level, that has been proven to be safe and effective by the Food and Drug Administration, and then rescheduled by the Drug Enforcement Administration.
So, and then the question is, without having really looked at the language thoroughly that you are recommending, are you also recommending special training or for folks, professionals who utilize the drug with patients? Because that's one of the things that we had talked about in our committee previously.
Yes, absolutely. Whilst training is not specifically mentioned in this bill, all training and everything related to training and administering of the drug will be determined by the Food and Drug Administration at time of approval with something called a REMS, a risk evaluation and mitigation strategy. So all of that will come down from the federal government at the time of the potential approval.
Good. And then we are also going to have to look at that in the context of our state. So FDA can say one thing, but then we always approve it.
So we'll hear from the Department of Health.
Oh, yeah, definitely.
Well,
Yeah.
sorry, do you mind?
In a minute.
Okay.
Yes, we will. And we'll hear from others who have comments to make about this.
Yeah, I was just gonna sort of echo what the Senator Lyons just said, which is, you weren't here a few years ago, but we did get a lot of testimony from practitioners who just, I mean, it exists. People are already getting help from psilocybin. So, and it was really, compelling testimony.
Yeah, I mean, and stepping out ahead so that we know that when FDA does whatever it is it's going to do, we're in sync with it. Let's hope it's not something a step backwards. Yeah. Okay, so that's it for H611. We have a lot of time on our hands this morning, so I'm gonna suggest to the committee two things. One, is today Wednesday?
Yes.
So when are we doing budget?
Friday.
Okay, we have the budget coming in Fridays with Nolan, and, Amy Pope. We'll look at that, and then we're going to ask folks if we have time Friday. Otherwise we'll do it another day. We'll be scheduling people. Here's the way we're looking at the budget. We're doing just a pretty not in-depth look. We're looking at the budget overall. We're looking at what was in the governor's budget, what the House has passed, and then there are other things that have not been included, and we'll be hearing from people who were either, in their opinion, were underfunded or not funded. So we'll be looking at that separately. So when Nolan and Amy come in, we'll just be getting our arms around what's there in the budget. Our goal is to try to make some recommendations down the hall. So not carry them down there. There are some things I think important to us. So you have to think about, everybody right now is contacting us. I know, and I keep saying, no, I can't talk. So we'll hear from people going forward. And do we have something else on our agenda?
Looks like it.
What else is on our agenda? Let's have it. Oh, well, that's after adjourn.
It's not on the
Oh,
version.
got it. Thank you. All right, so we're gonna move on to that, but just so you know, that's what's coming. You don't have to dive deeply into the budget. It's really what your thinking is about what the needs and gaps are within your district or in here, the things that we're hearing. And we do have a little bit of work for us. That was wonderful. The other thing I'll ask of you is to look at the bills that we have up on the wall and let me know the ones that are important to you. Try and get through as many as we can. Okay. So now that I can see how my agenda is structured, I can move to H. That was your April Fools? You had that is cruel and unusual punishment. Oh, okay, so we're gonna move on to page 660. We have not been through the bill. We're gonna sort of, is Katie coming in? Okay, so what, we'll start with the reporter. Are you the reporter?
That I am.
That's wonderful. So why don't you come up on page 660? And I will say to the committee right up front that I have a lot of interests and suggestions and a lot of work for us to do around and within this bill. Just say that. So Representative McGuire, good to have you back.
It's good to be here, Chair Lyons. Thank you for having me.
So what I would ask of you is to give us the kind of the overview of where it was and what's in it, just generally. We'll go through it in detail with you.
Yeah. I'll lay off the how everything's been appropriated and so forth and what. So for the record, Representative Eric McGuire, House Human Services Committee. Again, Senator's Chair, thank you for having me. As I just give a brief overview of H 660. H 660, the bill that directs the fiscal year 2027 appropriations for Vermont's opioid abatement settlement fund and the substance misuse prevention special fund. The goal of this bill is to ensure that settlement dollars continue to support a balanced statewide response to opioid use disorder strengthening prevention, treatment, recovery, and harm reduction services while building long-term sustainability within the system. H660 allocates funding across the continuum of care with investments in community outreach, recovery housing, syringe services, peer recovery coaching and correctional facilities, and transitional and shelter-based supports. This includes funding for 26 outreach and case management positions, expanded recovery residence capacity statewide, syringe service programs, and peer recovery coaches in both facilities and probation and parole offices. The bill also supports shelter-based harm reduction programs and the creation of additional NAR certified recovery residence beds and underserved regions. The bill further includes youth focused prevention investments in substance misuse prevention special fund, directing funds to community programs in Barry, Connecticut River Valley, Windham County, and Winooski to expand youth engagement, prevention programming, and family-centered education. H660 also strengthens statutory requirements for the Opioid Settlement Advisory Committee, which I have the opportunity and pleasure to serve upon, ensuring board consultation with individuals with lived experience of opioid use disorder, frontline professionals, recovery centers, and the Health Equity Advisory Commission. Bill requires that ongoing funding requests include a sustainability plan, recognizing that settlement funds are time limited and must be used strategically. Quickly, just the program review and stewardship. Also, the bill is to ensure long-term fiscal stewardship. The bill temporarily pauses the acceptance of new funding proposals for FY 28, except for initiatives already designated for annual support, and directs the Department of Health and the Advisory Committee to conduct a thorough review of prior appropriations, program outcomes, and sustainability. Revisions and unspent prior year funds are also returned to the opioid abatement special fund, and H660 will take effect July 1st of 26, aligning with the start of our fiscal year of 27.
Thank you for your work on the advisory committee. Maybe what you could share really briefly with the committee is how you go through and listen to folks making a request of what's in the fund. Yes.
Well, this year, the committee took 67 applications were submitted to the committee. Through a review process, we were then tasked with reviewing all 67 of them, and then more or less pulling out a total of the ones that you're seeing funded here, which was 15. It doesn't mean that all these applicants weren't eligible for the funding. It is a finite bucket, and therefore we have to allocate wisely, and what we see as the most effective approaches that way. It's equitable across the state, different regions, whether it's through the ones that are aligned on harm reduction, prevention service, treatment service, recovery beds. After we get done going through the initial review of the applications, we came back as individual members with our recommendations. Through that, then a more or less consensus was taken, and the majority then got reviewed, and there was 15 of them. We brought each one of them on in. They provided their overview of what they needed the funding for, and then we made the recommendation on to apply it or not. It is it was difficult and challenging at times because we are limited to the amount of times that we can meet. So usually the first couple of meetings are then designing what the application process is going to look like, and then the applicants start coming on in, and the next meeting is getting together and work through this. Then the following meeting is at where you really are overloaded with information, and at times not getting all the information can result in maybe knocking out a couple of agencies that really could have fit the need much more than the next. But that's needed. And so it's And I believe that's why we looked at stepping on that, this going around and say, hey, let's use the committee to oversee what's already been provided, get some feedback, get some data, get to know whether or not how we're funding these things are working, are being productive back into the community, and then CSAT and just keep the funding going for those 4 initiative things. So,
Okay, thank you. And the voting committee,
pass out of our committee, 11, Madam Chair, I am sorry.
what was it, 1100?
I'm sorry.
Okay.
No, I believe, one was not, I am, maybe help me out with this.
Oh, gosh. Don't worry about it.
1001.
1001. All right.
Yes, pass out
Somebody
committee
stay calm.
1001.
And then voice vote on the floor?
Pass.
Yeah, okay,
Yeah, it was on, roll call.
okay, yeah, good. That always helps us to know this stuff.
This is a special fund, so this money came in from something.
We're gonna hear from Nolan and Katie, and so we'll get the historical data on this, and I can also go over that.
I figured.
Yes,
For the record, no language at this, but when you have me come up, I have a sheet that has the history of OSAC recommendations, the health department recommendations, what human services recommended, what passed the House.
excellent.
So you can do a side by side and a historical of what's been funded of those before.
This is exactly what we need.
So you can decide whether you want to hear that or the language.
We're gonna start with you on that, so. But any questions for Representative McGuire?
Really brief question, if you, Chairline, it sounds like the decisions you made were all data driven and you used evidence that you had and
No,
yeah, it's great. Thank you.
no, just a quick also backstory. We did submit, as the OSAC committee, we did submit our recommendations to, Human Services. Also, AHS submitted also a set of recommendations. So we were responsible for kind of bringing them all together. Most of them did align. So, yeah.
That's a new process. Anyway, that's interesting. AHS, but your recommendations go to the Commissioner of Health. So that, and then the Commissioner of Health makes recommendations for purposes of appropriations. So, but just thinking procedural. Okay. Thank you. Thanks for your work on this.
Yes, and there was also an amendment to the bill.
Uh-oh.
And that's in the new bill, yes. The amendment to the bill was to remove, and I think Nolan may be able to explain a little bit better. There was 3 that were allocated out of the prevention. 3 recommendations, and we designated them over to the prevention on the amendment that was put on in. Puts those back into the opioid, the OSAC.
It's on my sheet. I account for that in my spreadsheet.
Okay.
Yeah, so the substance use prevention fund is a different fund and not ordinarily touched here. I'm sure that everyone would like to get to it. As I was,
Who doesn't like free money?
and I know, it's money. Look for it. All right, thank you very much.
Thank you very much, Senator Lyons, Chair Lyons and committee. See you all tomorrow.
All right, now we're here. So I'm looking at Katie and Nolan. How do you want to do this,
Up to
Katie?
you. Do you want to do a run through the bill and then have me?
What makes sense? Katie, do you want to go through it? Or-
I don't,
And the
I
bill,
think either way works. I can give you a little overview about the,
Let's do that.
okay.
I should do that.
And then we'll have Nolan come up and show us the picture. So, and I just will say up front that because we've been focused in here on substance use disorder prevention, recovery residents, recovery services, that there's a huge amount of interest in accessing the opioid settlement fund to use for any bill that comes in or any idea that comes in. So it sometimes can get a little bit confused. Our goal is to try to sort all that out. The substance use prevention fund is another fund that we also need to sort out in here. What are the criteria for use? What are the guidelines? So this bill raises a significant number of issues for us that we want to look at. I know that the administration would like to use all the money. The advisory committees would like to use all the money. We would like to use all the money. The recovery residences want to use all the money. So it all lands right here. Here we are. Okay. So let's look at H6.
Sure, taking like that off the legislative council. So there's the opioid abatement special fund that was established, I would say maybe 5 or 6 years ago at this point. And this is funds from settlements from litigation with pharmaceutical companies that produce opioids. And every year, there are appropriations from this fund. When this fund was initially created, one of the requirements of getting the funds was having a advisory group to weigh in on how the fund should be spent. So in our statutes, we have several provisions about who is on the committee. There's also language in statute about how the money can be spent. There are parameters that were part of not only the litigation agreement, but they were adopted into statute about how the money can be spent. So the practice has been for the past several years that this money has traveled alone in its own bill to make it easier to keep track of where the opioid appropriations are happening. So this is this year's iteration of expenditures from that fund. As Nolan was sort of teeing up and as his chart shows, sometimes the health department and the advisory group that's in statute have maybe different recommendations. So that happened this year, and you'll have that chart to work through to see where the differences were. Obviously, the House made decisions, and those were policy decisions. Representative McGuire is also talking about using the Prevention Misuse Fund. The committee report that Human Services passed out did have some of the items in the list in subsection A coming from that fund. Appropriations changed that and has everything coming out of the opioid abatement special fund. But language was added to have work done off session and by the advisory group to take a deeper look at what and when the prevention fund should be used instead of the.
Oh, so the advisory committee in the budget, I did read that last night. So the advisory committee is being given the charge to decide how to use the substitute.
I can't remember if it's the department or the advisory committee or both, but we'll get there.
Make a change to that.
Okay. So let's start with this subsection 1. This is just the fiscal year 27 appropriations. Subdivision 1, $455,000 to the Department of Health to fund 26 outreach case management staff positions with the preferred provider network for the provision of services that increase the motivation and engagement with individuals with substance use disorder in settings such as police barracks, shelters, social service organizations, and elsewhere in the community. This will look familiar to you because it has traveled. This has been an ongoing appropriation, and you'll see in this B, it is the intent of the General Assembly that these positions shall be funded annually with this fund, unless and until the special fund does not have sufficient monies to fund this expenditure. There are a few items in this list that have that subsection B, notating that they're ongoing appropriations, and that becomes significant. I especially want to point out because there's a report or maybe a change in practice next year that is specific, kind of creates a carve out for the ongoing items on the list. So I want to flag for you where those are.
Hey, can I ask a quick question? Who's the committee that was put together? Are they also do they keep going until the money is gone? You know?
I believe so. I don't think there's a sunset date, but I could double check if we put a sunset.
And one of the things we might want to think about is how to have other settlement funds go into this fund. So it's not just that initial set of guidelines and funding that comes in, but talk with the Attorney General's office about including more of the settlement funds. So you got a process going on.
You received, this is way better for Nolan to answer than me, but I know that since you've gotten the initial funds in this special fund, that there have been other settlements and more funds have come into it. So you,
So that it's continuing to
yeah,
increase.
I think that's maybe
Yeah.
not going to be an ongoing thing, but
One of the, I don't know whether it's an issue or not, but I know that when the initial settlement came in and I read all the guidelines with clear things that we could do, things that we might do and things that we had to do within the appropriation of those funds. And I do not know what's in the new set of guidelines through the AG's office. Maybe we look at that, or maybe we ask that advisory committee to look at it and
yeah,
think about it.
you may want to have testimony from the AG's office. I suspect that if we have not heard from them, then the statutory language we have in place
It's fine.
is probably sufficient to capture what is in the agreement.
I might just ask them that question. And see what it is.
Okay, next appropriation is 1.6 million to the Department of Health for recovery residences certified by VCAR. And again, we have that language to indicate it's an ongoing appropriation. Top of page 2, 850,000 for syringe services. Again, this subsection B identifies this as an ongoing expense. Subdivision 4, 1.1 million to the Department of Corrections to provide peer recovery center coaches in Vermont correctional facilities and in probation and parole offices to provide group and individual coaching and reentry support, which shall not be used to cover administrative expenses. 250 to DCF's Office of Economic Opportunity to support long-term programs as shelters for individuals experiencing homelessness, including harm reduction supports, transportation to recovery meetings and appointments and clinical nursing programs. Subdivision 6A, 900,000 to the Department of Health for the creation of new recovery beds that are NAR certified at level 3 or above. Remember when we did our recovery residence bill, I know you spent a lot of time looking at that chart with the different levels. 300,000 to the Department of Health for the creation of new NAR certified recovery beds in Brattleboro, Middlebury, Addison, Randolph, Chester, St. Albans, or any other identified region of the state. Top of page 3, 248,000 to the Department of Health for the pre-hospital Vermont EMS buprenorphine treatment program to expand training for emergency service providers on carrying and administering buprenorphine after administering naloxone. Subdivision 8, 35,000 to the Department of Health to subsidize room and board for individuals in Rutland Mental Health Services Transitional Housing Program. Subdivision 9, 237,646 to the Department of Health for distribution to Springfield Project Action to support public safety enhancement team coordinator positions in Bennington, Springfield, Brattleboro, St. J, and Central Vermont for the purposes of providing administrative support, meeting facilitation, data tracking, outreach event coordination, and sustainability planning. 288,935 to the Department of Health for distribution to Elevate Youth Services to support the creation of a low barrier drop-in teen center in Barrie to provide food, activities, positive adult role models, peer counselors, prevention and recovery programming, and direct connection to treatments. Subdivision 11, 125,000 to the Department of Health for distribution to Greater Falls Connections to enhance youth engagement and education and to expand prevention-focused staffing and youth programming space in response to increasing community needs. Top of page 4, 200,000 to the Department of Health for distribution to Interaction Friends for Change to increase access to community-based therapy, housing, crisis, medical recovery, and employment supports for youth in Windham County. And lastly, 26.5 roughly for the Department of Health for distribution to Winooski Partnership for Prevention to provide funding for staff time and stipends for partners to deliver medicines, safety education to elementary age youth during school with family engagement. Then we have language that unless reverted by a future act of the General Assembly, the appropriations that are made under the section carry forward until fully expended.
So there's nothing in here about the opioid protection, the LPC in Burlington that was supposed to be funded in an ongoing way. I think put that in there.
That's not in here.
Not in here. They have the record, no language on fiscal.
Yeah.
They received 2 appropriations, I believe, of 1.1 million each of the last 2 years.
So
They have money.
they're still
They
ongoing.
haven't opened yet. So the appropriation
Right.
has been made. There's money there for when they do open. But I think the thought is they'll need to give them money again when they haven't actually opened.
Well, we'll have to take testimony on that if it might be that when they open, they do need that money. We can't go back on a promise made, so.
The money is, there's still money
Yeah,
there.
no, I understand, but it was money that was there for previous years. And so all of a sudden, the dam opens up and they run out of water or run out of money. So we'll get to that. We'll get to that. It's just a question I have.
I don't see any prevention funds going to first. Sorry, is it on your list?
What,
I'm not specifically sure.
Just-
What are you-
that's good.
for the
I mean, okay, but
number of people with,
okay, well, rephrase my question. I don't see any funds going for in here. Did I miss it? Well, because I mean, a lot of other places like Rutland is specified and Wyndham County and.
There was at least one place where it said where it's open-ended.
Winooski has.
Any other
Yeah,
identified
Winooski has a
region of the
small
state.
amount. Any other, where was that?
And so the 300,000, 6B.
There's surrender money, goes to.
Okay, well, these are questions, Senator. That's what I have.
Okay.
Is there anything else here, Katie?
Okay, section 2 of the bill, there are 3 reversions in this bill from past appropriations that were either unspent or the program concluded without spending all the money. Different reasons for each one. Those are dealt with in another section later on in the bill, but so this number changes in a different portion of the bill, but there are language changes for this particular reversion to conform with a monetary change. So this would now read, so this is an appropriation from fiscal year 23, 1.5 million. Instead of divided equally between 4 opioid treatment programs, would just be 1.5 to cover costs associated with partnering with other healthcare providers to expand satellite locations for the dosing of medications, including costs associated with satellite locations, physical facilities, staff time at the satellite location, etc. Subdivision B, the satellite locations established pursuant to the subdivision 1 shall be located in Addison County and eastern or southern Vermont, and striking through DOC. That's where we get the strike through of 4. What's equally funding 4? That's why that is struck through. And then we have this language 500,000 to establish a satellite location in northwestern Vermont instead of a second Chittenden Clinic Addiction Treatment Center. Okay. That brings us to section 3. This is the Opioid Settlement Advisory Committee. As I mentioned earlier, this is statutory language that is already codified. It was the advisory committee that was created when the special fund was first created. This is the powers and duties of that advisory committee, and there's a proposal to change some of that language. Right now, the advisory committee is to consult with individuals with direct lived experience, etc. There are a bunch of different entities. So being added to the list of entities that the advisory commission would consult with is the Health Equity Advisory Commission that exists in statute. And then we have this new sentence being added on page 6, line 5 through 8. Each ongoing funding proposal considered by the advisory committee shall include a sustainability plan from the applicant to ensure consideration of future expenses and available resources apart from the opioid abatement special fund. So this is saying if there is an applicant that is bringing a proposal forward to the advisory committee and it's not a one-time ask, it's something that would be ongoing, that part of the application process is to think through what future funding would look like for that. Okay. Section 4. Okay, we have 2 provisions here. Subsection A. On or before December 1 of this year, the Department of Health is to review all previous appropriations from the special fund and make recommendations to the advisory committee and the policy committees regarding which appropriations could be funded in future years by the Substance Misuse Prevention Special Fund. So this is where we had the conversation and I couldn't remember who was doing the reviewing. So it's the health department that's doing the review, and that information is being recommended to the advisory committee.
And the recommendations are just about future,
Yes.
okay, because I wrote a note
Well,
down
no.
myself.
Shall review previous appropriations from the
Previous.
special fund.
And, but then which appropriations could be funded in future years. So I wrote a note down myself to ask about how this all fits in with the strategic action plan that we have going in place, which is critical.
Subsection.
So I'm just
Sorry.
thinking maybe a different way to do this. That's all. I don't know.
Okay. In subsection B, the advisory committee is not to accept new funding proposals from the special fund for fiscal year 28 unless a proposal was previously identified in statute as intended for annual funding. So that's why I was pausing at those 3 items on the list where the General Assembly has designated, those are for ongoing funding. Those are exempted from this. It instead shall review the outcomes of programs and initiatives previously funded through the special fund to assess effectiveness, long-term sustainability, and the appropriateness of the special fund as a funding source where applicable.
So I probably should have asked Representative McGuire this question, but where did this come from? Did the recommendations here come from the advisory committee?
This clause.
The whole thing, these last sets of recommendations.
They came, well. The
Because
subsection
that's
B
not
came
part
from
of their,
Human
is that part of their
Services.
charge? I guess it might be the part of their charge, to make recommendations.
Well, B came from Human Services,
Okay,
this came from appropriations, because there's a back and forth between Human Services and appropriations about the use of the prevention
got it.
fund. So that's where those 2 pieces came from. Section 5 is the reversions, and I will very happily let Nolan walk you through those.
That'll be fun.
And that's it. That takes effect July 26th.
And if I can, the addition of looking at substance misuse fund came out of require. There was 4 appropriations that they had said, we don't want that to go to OSAP, we want them to go to substance misuse. Appropriation said, actually, we think it should be in the OSAP, but let's do a review of the substance misuse. So they added that language into
Understood.
there. So that's where that history.
Yeah,
And I'll
and I
go through that change.
Yeah. And I looked at the language, it's in the budget, pretty big deal, but the question is, I think we're gonna have to wrestle with the question about these 2 funds and how they fit together, and I'm not real keen on giving all of that money from the substance prevention fund to an advisory committee set up for something else, so we're just gonna have that conversation. And we need to know what the guidelines and criteria currently are for that, for our substance misuse or prevention fund. And because the advisory committee, it's great, and you get good people on the committee and they have lots of good ideas and want to make recommendations. And then we start to see mission creep. I'm feeling mission creep all through this bill. So, yeah, that's Katie, sorry. All right, Katie, any questions for Katie? Thank you.
Okay.
All right, so Nolan, No, obviously, we're gonna have to come back to this one. Katie, we're gonna have to come back to this bill and do some work on it. And I do share with the Senator Julick's question regarding Burlington. And I'll tell for a couple of reasons. One, the OPC has gone through and there was money for it. And now it's been cut off. Whether that is an accurate belief or assessment, that it's supposed to get the next step. That's one. Two, we have a very high density of people needing services in Chittenden County. Not mentioned in the bill except for newspaper. Three, there's a rural health transformation grant that for some of these things is quite available in every county except Chittenden County. So I don't know whether the advisory committee had that in mind when they did this. They probably did. They probably didn't know about it. So, okay. Like heavy lifting. Oh, Nolan, thank you for being here.
For the record, Lowell Lamb, joint fiscal officer. I've made hard copy of this because it's just a lot easier to follow as we deal with things.
Oh, you got it.
And Katie, I don't know if you want one.
Wow, this is nice.
So I'm not gonna go over my fiscal note, because I think the fiscal note really is just like reiterating what Katie said is in the bill.
Yeah.
If the one thing I will orient you to on the fiscal note is with the last page of fiscal note. I have this. This is the estimated allocations to the opioid abatement fund till it's done. Just to give you a sense of gosh, Robin, you're trying to.
Oh,
Sorry.
that's really good. Can we introduce you? Are you here for us to be introduced?
Well, I'm here because I have a colleague from BC. This is Erin Doty. We work at Senator Welch's office on Robin Lunch. Hi, everybody knows me. And Erin is new to the office. She's been working for Senator Welch in DC for 6 weeks. She's been on the Hill for 20-ish years. But she's new to Vermont. So I'm dragging her all around and brought her to the State House.
Can we introduce ourselves?
Yes,
so we get
please.
so Aaron gets to know us.
Yes, that would be wonderful. I'm sorry to disrupt your whole.
Yeah.
Yes, whatever.
So thank you for doing that. Yeah, sorry, didn't you know you're coming? We would have you sit in the chair.
Oh, wow.
So I'm going to start. I'm Senator Ginny Lyons. I represent Chittenden Southeast, which includes a teeny bit of Burlington and a whole lot of rural towns in Chittenden.
I'm Senator Martina Rock-Ulick. I live in Burlington and represent Burlington, Winooski, Essex Junction, Essex Town, a little bit of Colchester.
I'm Ann Cummings. I represent Washington County right here. And Senator Welch said I'm his former boss. He served on my committee.
We'll tell him hello from his former boss.
From everybody.
John Morley from Orleans District, representing 20 towns, and Senator Welch sent me a very nice letter wishing me well in the Senate. So it's nice to meet you.
Great.
John Benson, I represent the folks of Orange County.
So there we are. This is Senate Health and Welfare. We're going through some money that comes from the opioid settlement fund
Terrific.
that based on litigation with the pharmaceutical industry. And we're trying to sort out what's in the bill before us and then what we need to do further.
Great. I thought we just listened for a few minutes and then I'll bring her along.
Thank you very much for being here, for coming in.
Yeah,
Thank you.
Thanks for having it.
So before I was so rudely interrupted.
And finally, give our best to Peter Bob.
Gave rousing speech here and stuff.
So what I have here, it's going to orient you a little bit. So what I have here, this is the fiscal notes on the last page, and this gives you a sense of the estimated allocations to the opioid abatement special fund through 2037. It accounts for all of the allocations we're expecting to get, except for the Sackler Purdue settlement, which hasn't quite come through.
Hasn't happened yet.
We don't know how much it's gonna be and how it's going to be. Most of the settlements are, some were one time, some were overtime. When I spoke to the AG last about this back in November, December, they didn't give me a number, but they said it could be in the 20 million range, it might not be. And it could all come at once or maybe not. So, but we don't book it until we get it. So it's not on here, but so when I get the question like, oh, how much money are we expecting to get, this will give you a sense. But to the other point, you'll notice it's diminishing. So this is a fund, and this is what the Human Services Committee had in mind. Like they were thinking about like, this is not a permanent fund, it's going to start to dwindle. So when they came up with the idea of having the recommendations for the future, they wanted the OSAC to be mindful of what should be ongoing and what should not be ongoing, and also for the health department too. And they've already started doing it. And then their recommendation is is an OSAC, what is an opioid special fund thing that could be switched to general funds or become base budget. I know the administration has at least one proposal that switched over from being a special fund to a base appropriation because they said, hey, this program's working, we should fund it. I'll let them talk more about that in the future, but it was in their budget.
Oh, wait, is that in the bill or is that in the budget?
It's in the budget.
It's in the budget.
It's in
I
the
thought
budget
that- yeah.
proposal, and the House didn't do anything, didn't adjust it, so it's there. I think it's an employment program.
Yes.
So now to go to the sheet, so let me orient you to the sheet. Did I unzoom myself? Oh, there it is. Here we go. So I'm just gonna put it on the screen, but I'm not gonna move it around. I'm gonna just do the old fashioned way, and I'm gonna orient you. So it's broken up into multiple sections. So first you have, these are existing ongoing initiatives. And you can see going across, you have EDH recommendation as health department, the OSAC recommendations. Each of them provided separate reports, recommendations to the committee. And that's, I'm sure that we can get copies of that. You can hear from each of them. But I went to that report and I compared what each were saying. So you can see some of the appropriation recommendations were saying, like outreach and engagement. They both said 455. Some of them were not. For instance, emergency shelter, BDH said we want to do emergency shelters. So OSAC did not put one for emergency shelters, right? And then you have the third column, which is the House proposal. Sorry, the Human Services proposal. These are the things that they said, okay, we've heard from BDH, we've heard from OSAC, we've heard from other folks. This is what they're putting in their bill. And then you have what passed the House, essentially, finally. And where the key differences are between the Human Services proposal and what actually passed in the House were the things that Representative McGuire flagged. And that would be under the new funding, and I'll get to that in a second. So the top is existing ongoing projects. So off to the right, you can see of those existing ongoing projects that were in any of the recommendations or reports, how much was spent on the past on those things. This does not include things that we have spent money on in the past and are not being recommended going forward. There are a lot more of those. This was only focused on, hey, here's what's in the bill to go forward. And here, by the way, here's how those things have been funded in the past. So you won't see the OPC in there.
So your number one going basically on the right hand side in 2025, you did 1.9 and then nothing in 2024. And then in 2023, you did another 1.9 for a total of about 4.
Yeah. Correct.
And so there's no APC and OPC in here.
Not listed on here because it's not in the current recommendation. So it doesn't count for that. There's other sheets that have all the other things from the past.
Is it on here? And
No, it's not in
no,
here.
this sort of disappears.
Well, yeah. Oh, actually, no, I'll take it back. It is on the last page.
All right.
At the very bottom. And this was
There it
initiatives.
is.
So this is under a section called initiatives recommended for future funding, but just not in 2027. Right? So the OPC, so the health department did not recommend funding in the future. The OSAC said, we want to recommend in the future. We're just not recommending it this year.
And
And then you can see the history of it off to the right, the 1.1 in 24, 1.1 in 25.
I did meet with the mayor about this and others, so we will probably have to have a conversation.
All right, and then the second section, we're jumping around, is the new funding. So these are all things that have not been funded in the past and are funded in this bill. And again, I lay it out by health department recommendations, OSAC recommendations, human services, and then what passed. I'm not gonna go through each of them again, but what I am gonna do is I'm gonna flag the things that went between the substance misuse fund and the opioid fund.
Understood.
And the first one would be,
Okay, we're gonna come back to this. I want to go, we are. A lot. Okay.
so if you start to go to number 11 on the list, because I numbered them on the side, you'll see elevate. So you can see VDA did not make a recommendation. OSAC made a recommendation. Human
So,
ser-
okay, let me be clear here. So there, the OSAC, the opioid prevention committee made a recommendation. I want to be clear. They made a recommendation about using the other fund.
No,
Okay, they did.
so let's clarify
I
that.
want to be
The
very,
OSAC, yeah, to your point.
Yeah.
The OSAC only made recommendations about the opioid fund.
thank you.
Where the conversation about the substance misuse fund came in was when it was human services. Human Services Committee said, you know what? We think that these things really belong in the substance misuse fund.
And they added it in.
And so they moved it over into the substance misuse fund. They said, you know what? We think it's more appropriate there.
But appropriation ripped it out, right?
Appropriations took that out because the health department had already allocated all the money in the substance misuse fund. So there was no money.
Do it.
And they
left.
did that without our input.
Well, you could always adjust that in the budget, but
So we're back to the original.
so it's back to, everything's back
Right.
in, there's nothing in this bill that
From other.
recommends anything to substance misuse fund. And part of the reason the appropriations committee put it back, they went back and forth, what should we do? Ultimately, it came down to, we were trying to get a clearer accounting of the substance misuse fund, what has been spent, what has not been spent, and we couldn't quite get there in the time we had. I've worked really closely with the health department, they're very, very helpful, but we couldn't quite reconcile things. And so the appropriations committee said, well, look, we don't have the time to get into, well, let's put it in the substance misuse fund, but then what's been allocated by the health department, where do we take that out?
Yeah, I got it.
Because the health department made the case, said, okay, well, here's how we're spending those particular things. So the appropriations is like, there's just not enough money in the substance misuse fund. We don't have time to get into what should change because there was enough money left unless they make changes. So that's why they said, let's just keep it in the OSAC, but let's have a recommendation like where people look at both, what's appropriate. And to Senator Lyon's point, you guys can say, well, let's keep the the future of the OSAC in the OSAC or the OSAC, but maybe have a different group look at prevention funds in general and
Right.
special funds and whatever, so you can get there in the future. But that's the history of how they got here.
And so I did ask joint fiscal for a cost accounting of what's in the fund, the substance prevention, misuse prevention fund, and how it's currently being used. So this committee can provide guidance down the hall.
Yeah.
Or further. So it could be added in. We could make some comments within H660, which is separate from the.
Yeah.
So just so we know that this is really helpful. Thank you for clarifying.
Yeah, and also, so to be very clear again, just to reiterate, the bill only appropriates money from the opioid settlement.
Yeah,
There's no appropriation in any other fund.
It even
There's only the recommendations about looking at in the future how to deal with the funds.
Understood.
So Human Services had 4 appropriations. They had the Elevate Youth Services, which is 11. They had 12. They had 13 and they were 15. It was a total of $640,000. They said, you know what, we think that's more appropriate than substance misuse fund.
And that's the substance.
And so appropriations, for the reasons I said before, said, well, there's not enough money in that fund. We don't have time to get into the other fund. There's plenty of money in the OSAP. Let's put it back for now. And so everything is just one fund. So that's the only difference. The last, sorry,
Nope, I'm just
okay.
stipulating.
So what I do is I break out, so the column, I break out the total funding for the areas without the reversion. So it's total of 2.3 in new funding. There's 4.2 in ongoing existing funding. And then the subtotal is 6.6. So there's 6.6 million in spending proposed. Now you have the reversions. And so the reversions were recommendations from the health department saying these programs are done, or we spent all we're going to spend, and the contract came in under, and the committee's like, great, we agree with that. We'll either, and so you take the 1.4 off the 6.6, and you come down to the bill being a gross of 5.163.
Why is it being called reversions?
So they've always been.
Reversions called
Oh.
when you take the money and you revert it back to the fund because it's not being used. We do it all the time, it's accounting.
That's how we do
Got
it.
it, okay.
So the bill is proposing a spending of 5.163 million. We'll take reversions.
And so as passed by the House,
Yes.
the reversion is that, we've got that.
Yeah.
The recommendations rather, 5.1.
Yeah.
And
And then you
that's
have,
the House that's the House passed.
yep,
HHS was 4.5
because they had.
because they took it out and they plopped it into the other fund.
So that's the four, those are four appropriations for 640,000.
Yeah.
Out, and this puts it back in. Then you have estimated unappropriated balance as of 2/11/26. This is how much was in the fund. And so it's 11.8. So you take the 11.8 and you minus the 5.1. After you pass this bill, there would be $6.7 million on the bottom line until the next allocation comes in from the settlement.
Right. And we don't.
Yeah, this just gives, I was just trying to give people a sense of the money flow.
Is this an annual?
So,
Yeah, some of the, yeah, it should be.
So great.
no, that's okay. So it's the 6,712,741. Those are available monies.
Yes.
That the advisory committee is following the law about making recommendations. So don't get. I see.
I'm just.
I saw dollar sign.
But no, as I understand it, that 6.7 million is accounted for in your chart
Yep.
that says how long the fund will be available.
So the 6.7 is how much would be on the bottom line after you spend this money based on how much is in the fund today.
Right, I understand that, but what I'm saying, when you gave us the chart that said, here's how much money will be available in the fund each year
Yeah.
going forward. You're assuming that 6.7 million is available for the following year.
6.7 plus whatever comes.
Correct.
Yeah.
So if we took that away, it would mean short number of years, run out of money. Much sooner.
But in all fairness, 2028 was high. If you look at all the years, 2028 was the highest, I think. Wasn't it?
I like this.
No, 2020, you're close. It's actually 2029, but by like
High.
$20,000.
It's not the decline isn't a straight line.
The decline starts around 2030,
Yeah, drops.
2030.
Okay.
It's a
Yeah.
big drop in 2033 and then another big drop in 2034 and then. Now, again, that doesn't include the 20 million or the estimated roughly 20 million. That may or may not come from the cycle.
Yeah, I know, yeah. Okay,
So,
Okay, so go through the last bit, so because we're getting
Yeah,
to
sure.
pumpkin.
and then, so the last bit, we jumped to it quickly, but these were initiatives. So the way that these reports came from the OSAC and Health Department and said, here are things that are ongoing that we think should be funded. Here are things that are new proposals that we think should be funded. And then here's some other initiatives that we think are important that you should fund in the future, just not now. And so that's how I broke this out. So this last piece is recommendation for future funding, just not for 2027. So that has the contingency management, both OSAC and and Health Department agreed with that. The syringe services program, and I'll get to that in a second, and then the OPC, which only the OSAC recommended. Now, I just quickly want to go to the syringe services program, where both the Health Department and OSAC says, you know what, we think this should be funded in the future. We just don't think it should be funded now. And Human Services said, we do.
Yeah.
So they put it in, so even though it's down there, you'll see it's actually carried
I saw.
on line 3.
It's in the budget.
So they put it,
It's in the numbers.
so it's in the numbers up above. So again, they said, we don't think it's funded this year, and Human Services, we think it's important. And the House said it, so they put back in.
So there's nothing in here that allows for the Joint Fiscal Committee to approve the continuing funding for the OPC should that become operational when we're out of session. That's a thought.
What I will say, Madam Chair, was there was a period where there was a flurry of conversation around, as you know, the OPC has been trying to find a place to home itself. And so that's the moving piece. Is once they find a place, then things will happen quickly.
But I do know this, I know that it's getting close. And in my conversation with the representatives of Burlington in this, that once it happens, it's gonna happen. It's like a dam breaking. So we need to have that conversation there. And I will say, look, at all of these decisions were made in what, August or September? When was the last meeting they had for the advisory committee? It was made a bunch of time ago. So, you know, we need to kind of look at updating where we are.
The OPC, that's the OSAC?
No, this is opioid.
Overdose prevention, it's very controversial. There are some people who would wish it would go away, and I think there's some bias against it. But I can't. We did pass it in here, and we took a long time getting it right based on data. We don't want to go back and relitigate that thing, but we do want to make sure that it gets supported appropriately. It may not be everybody's favorite thing.
But say it's also one of those things that is very like time matters with the OPC, because if it's about saving lives like now, it's not in concert with recovery, obviously, but it was always supposed to be something that we needed now because we were in the midst of a crisis. So it just makes me sad to see that like the years tick by and we don't have it.
So anyway.
The last thing I want to say really quick, just really quick, this handout I gave you is a living document. And so if there are typos, which I continue to find, just let me know and I'll give you that.
We won't be too critical.
Yeah, John, Representative Morley's gonna be
Look at-
looking for them.
No.
On top of everything else you're doing, this is absolutely amazing.
That's awesome.
Really appreciate, and I appreciate your comment about the Department of Health and others helping you get all the data you get going. Thank you. Thank you, everybody. Well, we are calling it a wrap, and thank you for the day. We'll come back to all of these things.